Hi, this is Nursinga. This week we're talking about the endocrine system. The endocrine system works with the nervous system to regulate body functions and maintain homeostasis. These systems promote normal metabolism, growth, development, blood glucose control, and sexual functioning. This regulation is achieved via the use of a negative feedback system. Sensors in the body monitor hormone levels and adjust as needed. External or exogenous sources of chemicals that enhance or replace hormones may suppress the release of normal circulating hormones. One example of this is prolonged steroid use. This suppresses the release of corticosteroids from the adrenal cortex. Therefore, abrupt cessation of steroid use can cause acute adrenal insufficiency. Another example of a negative feedback loop is the regulation of insulin. After a meal, blood sugar levels rise. Beta cells of the islets of Langerhans in the pancreas release insulin into the bloodstream. Insulin helps the liver convert glucose to glycogen, and it helps the body cells become permeable to glucose. Therefore, blood glucose levels decrease, and further release of insulin is kind of thwarted. There are many glands throughout the body that store and secrete hormones. These include the hypothalamus, pituitary, adrenal, thyroid, parathyroid, gonads, and the islet cells in the pancreas. Exocrine glands are the type of glands that secrete substances via ducts to the outside of the body. Those would include things like lacrimation, salivation, sweating, and digestive secretions. Think of those as kind of the cholinergic nervous system, or the effects of the cholinergic system. Endocrine glands secrete their hormones into the bloodstream, and they're circulated to the target tissues or organs of the body. Hormones are chemical messengers that only act on their target tissues to create a specific physiologic response. And you can see from the picture here that there are just as many target areas as there are glands that secrete them. Let's look at some of these hormones in greater detail. Let's start with the hypothalamus and the pituitary gland. So kind of looking at the map, the hypothalamus is kind of the master gland of the body, and the hypophysis, or the pituitary gland, has two halves. The posterior pituitary doesn't actually create anything. The anterior pituitary does. So the posterior pituitary is kind of a storage sac, while the anterior pituitary creates hormones that are then either stimulated or blocked by the hypothalamus. So the hypothalamus creates and secretes ADH and oxytocin and puts them in the posterior pituitary for storage. The hypothalamus also secretes releasing and inhibiting hormones that act on the anterior pituitary that either stimulate or block a response. So the adenohypophysis, or the anterior pituitary, then either secretes or does not based on those inhibiting or releasing hormones: TSH, ACTH, GH, FSH, LH, and prolactin. The adrenal glands are responsible for what we refer to kind of like sugar, salt, and sex. So it's the sugar or glucocorticoids, the salts or mineral corticoids, so those are kind of our steroids, and then the kind of sex steroids like testosterone. Those are all released from the adrenal cortex. The adrenal medulla releases the adrenergic hormones epinephrine and norepinephrine. And then the other thing that we think about in there is aldosterone, which is responsible for kind of fluid balance, sodium reabsorption, potassium excretion, water reabsorption, and fluid balance. So cortisol is kind of the glucocorticoid that we think about the most. And this is responsible for blood glucose levels. It breaks down proteins, it builds fat. It also suppresses immunity and inflammation. It's like being on cortisone or prednisone for a long period of time. but it also really helps maintain blood pressure in relation with the aldosterone as well. So cortisol is pretty critical, and in times of stress, the body increases the release of cortisol. And the release of cortisol, just as an example of another negative feedback loop, suppresses the secretion of ACTH. Spironolactone, which is a drug you might be familiar with, which is a diuretic, is the exact opposite chemically of aldosterone. So where aldosterone reabsorbs water and sodium and excretes potassium, spironolactone gets rid of salt and therefore water, holds on to potassium. So that's kind of, they work on the exact same area in the renal tubules. The thyroid is responsible for receiving a stimulus from TSH and releasing T4 into the bloodstream, which is then converted to T3 by the liver. It's important to measure TSH, T3, and T4 to look at kind of the entire cycle and effectiveness of that system. So thyroid overall is responsible for metabolism and an increased response to catecholamines. Thyrocalcitonin, or just calcitonin, pushes calcium into the bone, whereas parathyroid hormone, or PTH, breaks down bone to release calcium. So parathyroid hormone elevates your serum calcium levels. So when you have hyperparathyroid, you're going to have hypercalcemia. When you have hypoparathyroid, you're going to have hypocalcemia, and all of the beautiful things that go along with that as well. The gonads are responsible for the secretion of estrogen in women, which is necessary for breast development, and then the maturation and cyclic function of the reproductive system. And in men, testosterone, which is necessary for the maturation of the reproductive system and secondary sex characteristics. The pancreas, again in the islets of Langerhans, is responsible for the release of both insulin and glucagon. So somatostatin regulates both the alpha and the beta cells. The alpha cells release glucagon and the beta cells release insulin. Glucagon raises your blood glucose levels by promoting hepatic glycogenolysis. So it breaks down the fat that's stored within the liver and raises your blood sugar. And then insulin lowers your blood glucose levels by promoting glucose transport into the cell. When performing your assessment of the endocrine system, keep in mind not only the patient's chief complaint, but also do a really thorough past medical history and consider their family history. Ask about nutrition, actually weigh them, talk to them about their sleeping patterns and their energy levels, how well they're eliminating, like the stool, and then their reproductive function. A lot of the initial signs and symptoms that something is wrong will kind of ping in those areas. Your head to toe exam should really focus on normal versus abnormal findings. So is there edema, tachycardia, exophthalmos, thyroid nodules, swelling? Can you oscillate a bruit in the thyroid? Things like that. So really think about, like, if this were, a thyroid cancer, what would my findings be? Look at your lab values. So chemistries are really important as well as urine, but specific hormone levels are kind of what we're looking at when evaluating the endocrine system. And then there are stimulation and suppression tests that we can run for most of these systems that will tell us whether or not that's the problem. All right, so if you run a stimulation test on someone that you suspect is adrenal, and if they feel better, then we would assume that that's the issue. And then imaging for tumors, especially like in the pituitary and the adrenal tumors, and to help us diagnose a problem. So let's talk about some specific disorders related to the endocrine system. The anterior pituitary, remember, is that secreting portion of the pituitary, and the result of a normally functioning endocrine system is homeostasis. T3 and T4 give us our energy and metabolism. They give us normal body temperature and ATP for our cells to do work. Cortisol gives us glucose and helps us manage stress. Aldosterone gives us fluid balance and blood pressure management. Epinephrine and norepinephrine give us our alpha and beta stimulation for the heart, the lungs, the blood vessels, and the pancreas, so that, again, we can manage our blood glucose, but also maintain blood pressure and normal cardiac output. Growth hormone helps us with bone density and muscle mass, and then progesterone, testosterone, and estrogen are essential for sexual maturation and reproduction. So if something goes wrong with that, if we don't have enough, we're hypopituitary, then we could do like ACTH stimulation testing to check to see if that's the issue, and then also check those hormone levels in the blood. If we find something that's missing, those hormones would be replaced, especially things like thyroid, our corticosteroids, and estrogen or testosterone. And depending on the age, if it was somebody who was still growing, then we would also replace growth hormone. Hypopituitary looks like hypoglycemia, hypotension, hypothermia, hyponatremia, hyperkalemia. So potassium's flipped on these two. Loss of bone and muscle mass, loss of menses, ovulation, and loss of reproductive abilities, hair loss, weight gain, and decreased libido. Hyperpituitary, on the other hand, is most commonly due to tumors in the anterior pituitary, and therefore the tumor needs to be removed, and that's a surgical process. And the person looks the opposite: hyperglycemia, hypertension, hyperthermia, hypernatremia, hypokalemia, exophthalmos, weight loss, increased bone density, coarse facial features, and irregular menses. The way that we get a tumor out of the pituitary is called a hypophysectomy. So we want to take out the hypophysis. And there are a couple different approaches. The transsphenoidal is the one you've probably heard the most about. And this is done if the tumor is confined to the sella turcica. And so basically they go in they push the lip up and go in just above the gum line and follow it back. So it's transsphenoidal. It goes through the sphenoid sinus and into the pituitary, and they can remove it that way. You notice in the picture here, the patient has nasal packing on the kind of side that they went through, as well as a nasal trumpet, and then she also has that like mustache dressing. So we're watching for dressing discharge. We're watching for swallowing as a sign of epistaxis, the dressing for CSF or blood. We're going to monitor neurostatus for any signs of increasing intracranial pressure. We're going to monitor I&O very carefully, because once your pituitary is removed, you could develop diabetes insipidus, so that we could have massive urine output. And then monitor the oral mucosa, because if you have to breathe through your mouth, your oral mucosa is going to get dry, and then there's increased risk of infection or skin breakdown. There's also an endoscopy, so an endoscopic approach through the nair that allows for fewer post-op complications. So we get fewer CSF leaks and less epistaxis. And they, instead of having to cut in the gum line and go up that way, they actually just go fiber optically through the nair itself and then through the sinus. Once you remove the pituitary gland, the patient will develop acute hypopituitarism. So they'll need lifelong thyroid replacement, lifelong corticosteroid replacement. Some patients will need lifelong mineral corticoid replacement as well. And then you need to monitor them very carefully for evidence of diabetes insipidus and to treat that with desmopressin as well. So you're going to watch for lethargy, hypotension, and hypoglycemia. And again, the big things we look at: hypothyroidism, corticoidism, and diabetes insipidus, or hypo-ADH. If the patient has too much growth hormone early on, so coming from like before the epiphyses are closed when they're little, they will develop what's called gigantism. And the growth is usually proportional. They can reach about 8 feet in height. If the growth hormone is in excess after epiphyseal closure, then the long bones don't continue to grow, but the face and the features continue to grow, and those also appear very coarse. And to give you an example, we have the gentleman on the left who is very, very tall. Those are adults standing next to him. And then the people on the right who have acromegaly, and you can see the transition from when they were younger to when they were older. And their hands, their feet, their nose, their lips, their ears continue to grow, but the facial features in general just get much coarser. Diabetes insipidus, or the term diabetes itself, means kind of like the running through of the urine, so that lots of fluid is running through. The patients experience polydipsia and polyuria. When it's diabetes mellitus, it's related to hyperglycemia, and when it's diabetes insipidus, it's related to hyposecretion of ADH. With patients who have diabetes insipidus, about 30% of them will not have a known cause, so it's idiopathic. 25% will have brain tumors, another 20% will be after brain surgery, like the patient who had their pituitary gland removed, and about 16% will be related to head trauma. So it's very important when you're caring for a patient who had a head injury, if they're experiencing polydipsia or polyuria, that you're keeping a careful eye on their eye and nose as well, and monitoring for diabetes insipidus. Patients with DI oftentimes experience nocturia and fluid volume deficit. They get very hemoconcentrated, including hypernatremia, because they lose more water than salts. They'll get hypotensive, tachycardic, very thirsty, tenting skin, turgor, and fatigue. The drug of choice is desmopressin or DDAVP, and that can be given sub-Q, orally, intranasally, or in the critical patient, it can be given IV. SIADH, or the syndrome of inappropriate antidiuretic hormone, has, put your S's together, so much ADH. There's so much water, there's so little urine. They have delusional hyponatremia and the signs and symptoms of hyponatremia. So it's important to watch for seizures. They're going to have lethargy, confusion, muscle twitching. You need to treat them right away, or you're going to end up down that seizure pathway, which allows you to lose an airway and you could lose your patient. The treatment includes fluid restrictions, sometimes diuretics, but you have to be really careful about electrolytes and not losing too many electrolytes if you're using diuretics. So definitely want to use more water, lose more water than electrolytes. So oftentimes we'll use a drug called declamycin, which is an antibiotic, and we don't use it because there's infection. We use it because it's increasing water loss through the kidneys. But we do want to give salt. So sometimes we'll give hypertonic saline to increase the balance of sodium and fluid. And then while doing that, then it's possible to use like a diuretic. All right, so those were kind of our pituitary disorders. Let's talk about some renal disorders. Adrenal insufficiency, oftentimes referred to as Addison's disease, is caused by a decreased release or efficacy of ACTH. Patients are started on steroids for more than 2 weeks, must be tapered, or they could have acute adrenal insufficiency. Addison's disease can develop acute adrenal insufficiency during stress or illness. So patients who have this chronically can have acute exacerbation due to illness, injury, stressful situations, and the treatment is steroids, Solucortef, Florinef. So our corticosteroids and our mineral corticoids, those are important treatments that will help us maintain blood pressure and glucose, and kind of avoid them going into hypovolemic shock. I really enjoy these nursing education consultant kind of nursing memory handbook that they put out. I think that they're great. If you're a visual learner, this is a perfect picture, and not to stereotype, because obviously everybody's different, but bronze pigmentation of the skin, changes in distribution of body hair, GI disturbances, weakness, weight loss, hypoglycemia, postural hypotension, And then Addison's crisis would be profound fatigue, dehydration, vascular collapse, so total loss of cardiac output, renal shutdown because of no perfusion, decreased serum potassium, decreased serum sodium and increased serum potassium. So this paints a really clear picture of kind of what Addison's disease looks like. If we have adrenal hyperfunction, we can have a couple different things. So Cushing's disease is hypercortisolism, and this can be due to problems with the adrenal cortex, the anterior pituitary, or the hypothalamus. When we have hyperaldosteronism, we refer to that as kind of Conn's syndrome. And if it's isolated and that's all that's wrong, and that presents with fluid volume overload. So there's too much aldosterone, it's holding on to water and salt, and it's getting rid of potassium. So the person has hypertension, a headache, hypernatremia, hypokalemia. And remember that, hypokalemia is going to impact the heart. Hypernatremia is going to have risk for seizures. Those two things are bad in combination together. Looking back at the hypercortisolism, the person also has hypertension, but they have hyperglycemia because the glucocorticoids help regulate glucose. So when you have too much of it, you have too much glucose, you get dependent edema, the skin starts to get very thin, you get fat maldistribution, loss of bone density, loss of muscle mass. So the treatment for adrenal hyperfunction is really based on the cause. So depending on where in the body, whether it's the adrenal cortex, the anterior pituitary, or the hypothalamus, then they might do a hypophysectomy, they might do an adrenalectomy, they might give medication to suppress the secretions or medication to control the symptoms. Cushing's disease itself is excessive ACTH production from a tumor, usually. So Cushing's disease is kind of different than just hypercortisolism or just hyperaldosteronism. And then there's something called Cushing's syndrome. And Cushing's syndrome is a much broader term. And this is where patients have an excess of hormone production, CRH, ACTH, glucocorticoids, and it can either be something that they're producing, or it can be iatrogenic, meaning that it's coming from an outside cause, which is usually administration of exogenous corticosteroids. So this would be like patients who have chronic disease that are on prednisone for a long period of time, like our COPD patients or our lupus patients, and they end up with this Cushing's syndrome. So personality changes, hyperglycemia, moon face, CNS irritability, sodium and fluid retention, lots of edema. They have an increased susceptibility to infection, which increases the risk then if they have to have any surgical procedures done. Males will develop gynecomastia, everyone thin extremities with big fat deposits on the face and the back of the shoulders, GI distress, increased gastric acid. Women lose their menses, so amenorrhea and hirsutism, so they start to develop facial hair, thin skin, striae and stretch marks along the abdomen is usually as common as well. Bruises, petechiae, osteoporosis, fractures are common. So, overall, having just a constant high level of steroids within the body, whether it's from an internal cause or an external cause, really puts you at risk of a lot of things, including ulcers and infections, injury. So pheochromocytoma is a tumor, usually unilaterally, so just on one, and it occurs inside the adrenal gland here. So you can see that there's the adrenal cortex and there's the adrenal medulla, and then the pheochromocytoma is within the adrenal gland on top of the kidney. So here's our happy kidney, and then there's our little tumor on top. The problem with the pheochromocytoma is that it's a secretor, so it's a hyper-secreting epinephrine and norepinephrine. And so both alpha and beta are way overstimulated. The person becomes tachycardic, hypertensive, headaches, palpitations, hyperglycemia from this just constant battery of the heart and the blood vessels in the lungs and the pancreas and the liver. So kind of the whole body is getting beat up. The patient oftentimes will experience, weight loss as well from that constant stimulation. The treatment for this is to remove it. So there's an adrenalectomy where they take the entire adrenal gland, or there's a cortical sparing adrenalectomy where they try to save the adrenal cortex. So, and this is an example of a cortical sparing adrenalectomy where they're trying to save some of it. Before the surgery, the patient will need to be on an alpha blocker for about 7 to 10 days. The target is to get the blood pressure to 120/80 or below, and they also may add a beta blocker for heart rate. And the reason for this is they need to get this down to avoid post-operative kind of like a rebound tachycardia and hypertension and hemorrhage. Post-op care then includes careful monitoring of vital signs, glucose monitoring, and then, always for all surgeries, pain, bleeding, and infection. All right, moving on to thyroid and parathyroid disorders. Let's talk about hypothyroidism. So early on, the person will just feel very fatigued, lethargy, increased somnolence. They'll start to have some weight gain. Notice maybe that their hair is kind of falling out, their skin gets dry. That everything, like you put your hands in cold water and it hurts. Mixed edema is non-pitting edema, so it's kind of this mucoid edema. They start to become constipated frequently because of kind of loss of peristalsis, and the abdomen becomes distended. So all of that is from a lack of thyroid hormone or decreased metabolism and energy. When the labs are drawn, you should notice that the TSH is elevated. And again, this is the negative feedback loop. So if the T3 and the T4 are low, the TSH is going to be high. Treatment with replacement like levothyroxine, which is Synthroid, is going to be lifelong. You can't stop once you feel better because your body isn't going to make any more and you're going to feel just as bad as you did before. But it is possible to overshoot. So once you start replacing the thyroid, you need to monitor to make sure you have enough, but you also need to monitor to make sure you don't have too much. Pediatrics hypothyroidism looks like this. This little lady has very textbook pediatric hypothyroidism, infantile or juvenile onset. And remember that the thyroid is responsible for feeding the brain as well. So hypothyroidism in pediatrics leads to developmental delays. The hallmark signs are this big round abdomen with a protruding umbilical hernia because they have loss of muscle wall strength, a large thrusting tongue, loss of muscle tone, and then delayed cognitive development as well. And we have to treat this as soon as possible for the best cognitive outcomes because these kids will not hit normal milestones, they will fall behind, and they can have permanent mental damage if it's not recognized and treated immediately. In pediatrics as well, you have to watch for over-medicating. So the signs and symptoms of hyperthyroidism in a little one would be the same as kind of an adult tachycardia, irritability, but then fever and sweating would be the other things that you would monitor for. The most severe form of hypothyroidism is what we refer to as myxedema coma, which is where the person has such low thyroid levels that the essential functions of the body don't work. And so they get hypoventilation because they have loss of diaphragmatic strength. And this leads to elevated CO2, which is hypercapnia, and decreased O2 or hypoxia. Now, we know then that this then leads to cellular hypoxia, which is going to result in anaerobic metabolism, which is going to result then in metabolic acidosis as well as the respiratory acidosis that's occurring. So we're going to have a mixed metabolic and respiratory acidosis, which is going to lead this person into a rapidly, downward spiral. Fluid and electrolyte imbalances are common as well. Hypoglycemia, hyponatremia, both of those are bad. Hypothermia, because the thyroid is responsible for maintaining core body temperature. And then loss of cardiac function, because the thyroid feeds the heart its energy that it needs to beat. So we'll get bradycardic, we're going to lose our cardiac output, and death is the end of this if we don't intervene rapidly with thyroid replacement. This is a perfect picture on the left of a patient who had severe hypothyroidism, and then on the right after she was treated successfully. And you can see how the edema has come out of her face and how much better she looks. Hyperthyroidism is either over-medication with Synthroid or levothyroxine, or from, in this case, a goiter or a tumor. It elevates the metabolism. The patient has tachycardia, a thyroid bruit, heat intolerance, increased peristalsis, so lots of good bowel sounds as well as frequent stooling, even diarrhea, hunger, weight loss, fatigue, nervousness, insomnia, weight loss, fine tremors, all of those things are possible. Fatigue is from the insomnia, not from the fatigue like hypothyroidism. Exophthalmos, which is the kind of bulging eyes that you see here, a goiter. And the treatment for this is anti-thyroid medication like PTU, tapazole, or lithium, or a thyroidectomy. In its most severe case, like a thyroid storm or thyrotoxicosis, it can be life-threatening. It can lead to cardiovascular collapse. So we have tachycardia, fever, hypertension, abdominal pain, tremors, altered mental status. The airways is always the priority, and fluids. And then think about beta blockers, anti-thyroid medications, steroids to maintain blood pressure, and a cooling blanket to reduce the temperature if the patient is hyperthermic. Thyroid cancer is when there's a tumor that is growing on the thyroid. And you can see here this female is palpating kind of a nodule or a mass at the base of her throat. If it is a fast-growing tumor, we can use radiation therapy. Chemotherapy can be used as an adjunct, but thyroidectomy is the treatment of choice for most thyroid cancers. Once removed, the patient will have hypothyroidism because they no longer have a thyroid, and they'll also have hypoparathyroidism if the parathyroids were as well. So when we have a thyroidectomy, it's either total, where they take out the entire thing, or subtotal, which is also partial. Patients with total thyroidectomy will be on Synthroid or one of the replacement therapies for life. If they take the parathyroid glands, then this can lead to hypocalcemia, because remember, hypoparathyroidism will lead to hypocalcemia, and hyperparathyroidism will lead to hypercalcemia. Hypocalcemia leads to tetany. So remember the Chavostex and the Trousseau sign, but it also can lead to tetany or spasming of the vocal cords, and therefore you will lose your airway. And that is critical. So you need to have a trach kit at the bedside. Oxygen, suction, bag valve mask, your rescue airways. Hypocalcemia and damage to the laryngeal nerve can cause loss of the airway. So during the surgery, if they damage the laryngeal nerve, you may notice just like a hoarse voice. But if they have like bleeding, you may notice some stridor. So there's a lot of things that can go wrong in that area from a surgical procedure around the trachea and around the larynx. So it's important that you have all of your resuscitation equipment there. Circulation, watch for hemorrhage, take a really careful look at the dressing site and also kind of down the back of the neck. Look to make sure that you don't have large hematomas or kind of pooling of blood anywhere. On the right here for thyroid diseases, people often ask, like, what's the difference between Hashimoto's, which is an autoimmune disease, and you can see how it damages the thyroid, to Graves' disease, which is also an autoimmune disease. We kind of see that in the middle there. And then a thyroid cancer, which is a carcinoma, kind of at the bottom. And last but not least, let's take a look at those parathyroids. So the parathyroids and the calcium work together. They move in the same direction. And opposite of calcitonin. So when you have hypoparathyroid, you have hypocalcemia. And remember that that results in like the tingling at the mouth, the hands and the feet, the chavastic and the trousseau sign, but you can also get the tetany and the laryngospasm and lose your airway. So the treatment for that is administration of calcium and vitamin D. With hyperparathyroid, you get the hypercalcemia, and that can result in pathological fractures because it's leaching the calcium out of the bones. It can cause kidney stones. So fluids, Lasix focus on safety, but you also want to stop additional calcium and vitamin D supplementation for the hyperparathyroid patient. So that is endocrine in a nutshell. Thank you so much for watching.